Thank you for joining us today. My name is Heather Robidoux, and I'd like to welcome you to the library. I would also like to welcome those that are viewing this from home today. Just a quick note, we do have feedback forms in the back. We would love your thoughts on today's program, but in particular, we want to know what programs you want to see in the future. Your feedback really does help us plan for those future events. Today's talk is part of a medical topic series. The library is proud to partner with UAMS Family Medicine and the College of Medicine. It's been a great series so far. This series features doctors, social workers, nurses, and other medical professionals presenting valuable information on a variety of health-related issues. We do have a flyer in the back listing all of the programs this year that are scheduled and all of the topics. Our next program is going to be on May 9th, and that will be Living with Asthma. So our topic today is migraines, those painful headaches that so many of us experience. And with that, it is my pleasure to introduce today's speaker, Dr. Natalie Rodriguez. Dr. Rodriguez is an assistant professor with the UAMS Northwest Regional Campus in Fayetteville and sees patients at the UAMS Family Medicine Center in Springdale. So with that, thank you for being here. I'll turn things over to Dr. Rodriguez.
Okay, I want to echo what Heather said. Thank you all for being here. For everyone that's watching online and going to participate with us. Now, I will say that my laptop is not mirroring up here on our projector. So I have my presentation pulled up. I'm not sure. But while we are getting those kinks worked out, I will talk a little bit about myself. I have a slide up there to introduce myself. That's always a part of these presentations, getting to introduce ourselves. My name is Natalie Rodriguez. I am originally from Texas. I grew up in the Houston area, about an hour outside of Houston, and eventually made my way up to Arkansas as a part of my education. So education started in the University of Texas at Austin. So I'm a Longhorn. There's not very much love for us Longhorns in Arkansas. You too? Okay. So I try to give us a plug every chance I get. So I went to the University of Texas. I got my Bachelor's of Science in Microbiology there. And then I went to Ross School of Medicine, where I received my medical degree, and then eventually came to Northwest Arkansas for my family medicine residency. And that is the end of the story. I loved it up here. I've stayed ever since I finished residency. It's a wonderful place to live. I work with the same residency program. As she said, I am the assistant program director for our family medicine residency, and I just really enjoy being here. I have a few hobbies that I was going to talk about. I love being outdoors, which makes Fayetteville another wonderful spot to live. I have a Great Dane named Kylo, which I had a picture of him up there in the presentation that we'll get to see eventually. I'm very involved. I enjoy music, and I'm involved in my church where I get to do that heavily. So I just really love it up here. Again, we're going to talk about migraines. Migraines is a very important topic to talk about because, like we have already said, we either have experienced them ourselves or, wonderful. Oh, this was my disclosure slide. We will be talking about some medications. I just wanted to make sure that we all knew that I have no type of financial tie to any of the medications that we will be discussing or any of the topics. No conflicts of interest within this presentation today. So as I mentioned earlier, that is my Great Dane Kylo. I have a little Longhorn here to show some love, and I work for the UAMS Family and Preventative Medicine. So, learning objectives for today. We're going to talk about what the actual definition of a migraine is, because we know that all migraines are headaches, but not all headaches are migraines. There are actually quite a few different types of headaches. There's tension headaches, there's cluster headaches, we have migraines, and being able to differentiate between the different types is important because that helps us to develop a better management plan. So we're going to talk about the actual definition, how we actually diagnose migraines, the different stages of migraines and what the symptoms truly look like, and then we're going to talk about the different treatment strategies. that we have for migraines. So this is what I was saying. This is why it is so important. 15% of the worldwide population suffer from migraines. It's a little bit higher in the United States, just by 1%, but it is the second most prevalent neurological condition that we face in healthcare. It's very, very prominent. In terms of age, usually the frequency, the severity, everything peaks in your 30s, but migraines can start for patients as young as 7 or 6. You can very much have pediatric patients with migraines, but it kind of peaks in the 30s. And then once you hit midlife, or once females go through menopause, we begin to see a decline in the frequency and severity. Women are more prone to migraines. It's a 3-to-1 ratio. And this is important for men to know because our brains learn to recognize patterns. And so we recognize the pattern of migraines with women, which, to a fault of our own, when men start presenting with migraines, it can take us longer to diagnose it, which means it can take us longer to get you on the correct treatment plan because it's just not as common. In terms of disability, so back in the day, migraines was an excuse to stay home and stay in bed, an excuse to not go to work. It wasn't given the emphasis that it needed. It is the second most common cause of disability in the United States, second only to lower back pain. These are severe, they're real, they really affect people's lives. So yet again, another important reason to talk about it. So as promised, we're going to define it. So a migraine is a chronic neurological disorder characterized by attacks of moderate or severe headaches with reversible neurological systemic symptoms. So that's a wordy definition. What this means is that migraines are it's a neurological disorder. It is moderate or severe. So these are not the headaches that you kind of wake up with and you go about your day and it kind of falls to the back of your mind and then you slow down, you're like, oh, that headache's still there, I need to take something for this. Migraines are debilitating. So it's in the definition. It has to be a pretty moderate or severe headache, not a mild. And then we will talk about some of these neurological systemic symptoms that we can see with migraines, but a key point is that they're reversible. When the migraine is over, the neurological symptoms resolve. This is the official diagnostic criteria. So we have heard of the American Heart Association, correct, for all of our good heart information, and we've heard of the American Diabetic Association that gives us all the research regarding diabetes. We also have an International Headache Society. So these are the panel of people that they put all of their expertise into researching headaches, researching the treatment for migraines, putting all of their resources into how can we better understand what's going on and how can we better serve our patients. And so they, through research and through studies and through discussions and panels, have come up with the official diagnostic criteria of what makes a migraine an actual migraine. So you have to have, there is A, B, C, D, if you will look, you have to have at least 5 attacks to be considered a migraine disorder, and they have to fulfill B, C, and D. So let's go over B, C, and D. B says that this migraine is not going to go away in 30 minutes. This has to last at least 4 hours. They can last up to 72 hours. So when we begin to look at how drastically a migraine is affecting one of our patients, we begin to count headache days rather than just how many headaches did you have this month, because we realize with a migraine, sometimes they last longer than 24 hours. So it needs to last between 4 and 72 hours. You need to have at least 2 of these characteristics. It's one side. We see pictures and representations of people with headaches, and they're grasping both of the sides of their head and they're leaning over. Those are commonly seen with what we call tension headaches, but a migraine is one side. It's unilateral, and so you see that, it's pulsating, it's pounding. People say, oh, I feel like, somebody's just hammering my head. That's another characteristic of a migraine. Again, like we talked about, it's moderate or severe pain in intensity, and then it is aggravated by physical activity. So this is why it can be so debilitating, because your normal routine physical functions can aggravate your headache, which is going to cause you to want to lay down. It's not going to allow you to fulfill the things that you needed to do throughout the day. And then part D is that a headache, a migraine, must involve one of these two. It's nausea and or vomiting, or photophobia and phonophobia, which is a fancy way of saying I'm sensitive to light and I'm sensitive to sound. So now we're going to talk about the stages of a migraine. So a migraine comes in 4 stages. So you have the green, which is the prodrome, the aura, the actual headache itself, and then the postdrome. And we're going to look at each of these stages more closely. So a migraine prodrome, what is it? First of all, it's very common. 77% of the people who have migraines will experience a prodrome. So that's 3/4. And what it is, it's kind of like the warning sign of what's about to come. Some people will have severe yawning. They just start yawning all the time. And that's their signal, I'm about to develop a migraine within the next 24 to 48 hours. Some people crave specific foods. Some people just feel very fatigued. They begin to experience the light and the sound sensitivity. Some can have bowel changes. It can vary with patient, but it happens 24 to 48 hours before the head pain begins, and it's a signal of what's about to come. Now going to the yellow section, the yellow stage of the migraine, we have the aura. So this is less common. It's 25% of patients who experience this. But what's specific about an aura is it's those neurological symptoms, which if you remember in the definition, we said that there were neurological systemic symptoms that were reversible. This includes that, okay? So they will have which can make it difficult because a lot of these symptoms look like a stroke, and we're about to go over them. These are the different types of auras that you can experience. The most common being a visual aura. 90% of the people who have auras, it's visual. So have you ever known someone who suffered from migraines and they see flashes of lights? That's what this is talking about. Sometimes it can be just actual vision loss. You know, people will lose peripheral vision, or they can have total unilateral vision loss from one eye. Second most common type of the aura is a sensory. This is usually like you can have numbing or tingling. A lot of times it's a perioral. It happens around your mouth, but it can also happen on one side of your face or in, one arm, which those are symptoms that really sound like a stroke. When I'm working in the hospital, we have patients that come in, oh, my right arm is tingling, or the right side of my face is going numb and tingling, and immediately it's a stroke workup. And so that's a lot of times we will catch some really bad migraines because we do the complete stroke workup. Oh, nope, no signs of a stroke. Now you have a debilitating headache. You have had a migraine with a sensory aura preceding it. Less commonly, you can have a language aura as well as a motor. With the language, sometimes these people begin to struggle with word finding. They'll look at a chair. I know that's a chair, but I can't think of what it's called. That's something else that can happen right before the onset of the migraine, or sometimes they lose the ability to speak at all. But again, that is much less common. And then the motor aura, which is the rarest form, is just unilateral weakness in one leg or one arm. Again, things that will make us be worried about a stroke. So now we're moving on to the third portion of the third stage, which is the actual migraine itself. So like we were talking about when we were looking at how to officially diagnose it, migraines, there's a POUND acronym that we use sometimes in medicine. P for pounding or pulsatile. Like I mentioned earlier, that hammering in your head, it's pounding. O stands for 1 day duration. Usually they're lasting around 24 hours. A lot of times sleep can help relieve a migraine. So when people go to sleep at night, they wake up the next day and their migraine has resolved. U is for unilateral, like we said. It happens on one side of the head. And then N is for that nausea or vomiting that is very often associated with a migraine. And then D is for debilitating pain. Then the last stage is the postdrome. I have woke up the next day, my headache is gone, but a lot of times people have this experience where, in their words, they'll say, I kind of felt hungover. My head If I moved it, it would still hurt, where the migraine was the day before. I just felt exhausted. I'm fatigued. Sometimes people crave a specific food following a migraine. That light and sound sensitivity can still linger. Even though the pain is gone, I can still be a little extra sensitive to sound or light. And this usually will last less than 24 hours. So these are just some rare subtypes of migraines that I just wanted to mention for completion. You can have ocular migraines. They are very rare. And this is, you can have, again, complete blindness in one of your eyes prior to the onset of that migraine, but it usually lasts for less than an hour. But something I do want to bring up, because it's going to be very important when we come to the discussion of how we treat migraines, and that's chronic migraines. So some people will develop chronic migraines, which is if you are having 15 or more headache days per month for at least 3 months. So that's half of the month you are suffering from a debilitating headache that is drastically affecting your quality of life, which makes sense why we see such a high percentage of disability being caused from migraines. Most common cause of it, or not the most common, but it's commonly caused by medication overuse, which I'm very passionate about, and we're going to talk about that later on in the presentation. So, we have a migraine. What can we do about it? Anytime a patient comes to me and they're concerned they have migraines, they know for a fact they have migraines, it is affecting their quality of life, they're coming to me and they're saying, how can I fix this? What can I do? First, I deliver the sad news that unfortunately migraines, there is no cure for migraines. And we actually don't even know what the official cause of migraines is. In the past, they thought it was due to maybe constricting or dilation of the vessels within the brain, and now we have realized it is so much more complicated than that, and there's still lots of research going into it, so hopefully we can come up with some better treatment plans in the future, but as for now, we don't know the cause, okay? And so when people come, I have to tell them there is no cure for this. So what we're going to focus on is how can I try to prevent them, and how can I treat them when they do happen. What we're really going to focus on today is lifestyle and behavioral changes, because this is a big deal. I will tell y'all, when it comes to migraines, your brain change equals bad, okay? If you're wanting to prevent migraines, you're wanting to establish routines, because those changes can trigger a migraine. And so headache diaries are very, very important when it comes to trying figuring out what your triggers are going to be for your migraines. A headache diary, we will often send patients. You can Google different forms. You can just write it down on paper yourself. We know that there are food triggers, there are stress triggers, there are sleep triggers. And so we educate our patients that when you have a migraine, think about the day before. Were you stressed? What did you eat? Did you not sleep well the night before? Did you drink a different type of alcohol? Did you drink more coffee than normal? Let's try and figure out if we can develop a pattern. That way we can change our routine to hopefully decrease this from happening again. So if we're thinking consistency and we're wanting to prevent change, when we talk about diet, let's do a protein-based diet, because your body will digest protein at a pretty even rate versus if I eat a carb-heavy meal and my sugar shoots up and then it plummets. Remember, we don't like these drastic changes, so we need something that's going to be more consistent, more even, and a protein-based meal, protein-based diet can help do that. This is the sad one. There are 5 C's when it comes to migraine prevention: cheese, chocolate, cola, coffee, and citrus fruits. So there are a lot of people who suffer from migraines who know for a fact, if I eat this type of cheese, I'm getting a migraine, okay? And I get it. We love cheese. We love coffee. We love chocolate, or I do. I'll speak for myself. But if I'm having debilitating headaches that's preventing me from going to work, or I'm missing my kid's soccer game, or I'm missing that vacation, I'm not enjoying it because I've got this headache that has knocked me down. I'm nauseous. I'm having to lay in bed. Well, I would be willing to sacrifice that chocolate, or I'd be willing to sacrifice that cheese. And these are things that if we keep a good headache diary, we'll be able to make those connections. Sleep. So not just valuable sleep, but that routine. Going to bed at the same time, waking up at the same time. Remember, change is bad. Exercise. Doctors always talk about you gotta exercise. That's because the studies are out there. We're not just saying it to try and get us all on some health plan. The research is there that if you will have a consistent exercise and consistent physical activity, either the frequency of your migraines will go down, the severity of your migraines will go down, or the broadness in the symptoms that you experience will minimize. Medication overuse, which I've already promised, we're going to talk about that here in just a few slides, and then behavioral therapy. So you may say, wait, just a second. Behavioral therapy, are you telling me that this is just all in my head? Why are you trying to send me to therapy because I'm having a migraine? Well, we know that stress can trigger migraines, and a behavioral therapist is the trained person to give you tools in your toolbox on how to cope with stress. Life is stressful. Work is stressful. Family is stressful. You turn on the news, that can stress you out. You can have a worldwide pandemic, that can stress you out. Those are things outside of our control. But the way that we are able to cope and face and deal with these internally makes a difference. That's within our control, and by going to a behavioral therapist, someone who is trained in things that we can do, exercises, tools to put into our toolbox, that's why we recommend behavioral therapy. So some of the precipitating factors, there you go, emotional stress. 80% of the people who suffer from migraines know for a fact emotional stress can trigger a migraine. That's why we push behavioral therapy. Not eating. 57% of the people say, I have a migraine when I start skipping meals. And we're busy, life is busy. But if I can train myself to maybe keep a protein bar in my bag, because if I can pull that protein bar out of my bag and prevent myself from having a migraine the next day, well, I'm gonna do it. We know that hormones can trigger migraines, especially for females, because we have a monthly cyclic fluctuation of hormones going up and down. So there are different birth controls that can help affect that, or even in terms of planning. If I know that around a certain time of the month I'm going to have a migraine, well, maybe that's not when I'm going to plan my vacation if I can do anything to prevent it. Exercise, sleep disturbance, 50% of the people know that changes in their sleep patterns will trigger a migraine. Odors, specific perfumes, specific candles, people have realized have been triggers. Lights, alcohol, smoke, heat. These are all things that we can control that will hopefully help prevent a migraine attack. So medication overuse headache. We talked about how it's a very common cause of chronic migraines. I'm very passionate about this because sometimes, we say health is wealth. Have y'all heard that before? Health is wealth, okay? The better educated we can be, the healthier we can be. And when it comes to medication overuse, if there can just be a little bit more education on the dangers of this, then we can live a healthier lifestyle, aka a wealthier lifestyle. So I always explain it to my patients like this. If I drink coffee every day, and then you take my coffee away, what happens? I get a headache. We know that. The same phenomenon happens with some of these medications that we take to prevent headaches. People will, I'm getting a headache, let me take a ibuprofen, or let me take one of my migraine medications. I'm worried I'm going to get a headache. Let me go ahead and take one. And your body can get used to that, and then you take it away, and it says, I don't have my medication. Now I have a headache. So we can see that same pattern. So always really want to caution my patients that this is real. I have had patients come to me in clinic who have, their doctor retired, and they're looking for a new doctor, and they're taking their medication every day. And when I start talking to them about, that's a cause of this, we got to cut back on that, I mean, it is stressful. They can start crying because it's real. It's a real headache that you experience when you're withdrawing from that medication. So this is something we really, really want to prevent and really educate on so that we don't have a higher percentage of people who suffer from this. What puts you at risk of that? If you use your acute medications at least 10 days a month. That is what we have said the threshold is for putting you at risk of developing that medication overuse headache. Some other risk factors can be if you are a cigarette smoker, depression, anxiety, if you have a history of substance abuse personally or within your family, if, sorry, this should have been a hyphen there, a co-use of a sleeping medication along with your abortive therapies for your migraines. And then which medications put you more at risk of developing that, or any of your opioids. Butalbital underneath is a very common migraine medication. It has an opioid in it. It's mixed in with some caffeine. Surprise, surprise, any medications that have caffeine added to it just puts you at a greater risk of having a medication overuse headache if you use that medication frequently. And then triptans and NSAIDs, which we're going to talk specifically about because they're our go-to medications for treating migraines, same thing. If you use them more than 10 days a month, then you can really risk developing that medication overuse headache. So if we remember, I'll just flip back when we're talking about the management plans, okay? First, we talk about lifestyle and behavioral strategies. Then we talk about abortive medications and preventative medications. So abortive medications, I have a migraine. I need something right now to stop it, okay? That's the abortive class. Preventive medications. These are the people who have the chronic. They are having at least 4 migraines a month. Maybe they're having 3, but they're severe and they're debilitating. Then we say, okay, maybe we need to look at a medication that I don't just take when I have the migraine, but a medication that I'm now taking every day to try and prevent the migraine. So let's talk about our rescue medications first, the abortive. I have one, I need it to stop. What can I do? So NSAIDs are wonderful. I love NSAIDs. This is your ibuprofen, this is naproxen, this is diclofenac. The reason I love NSAIDs, 1, because they're very effective. 2, they're cheap. 3, you don't have to see your doctor to get a prescription for these. I'm on vacation, I got a migraine, there's a Walgreens. I can walk into this Walgreens, I can buy some ibuprofen, or I can buy some naproxen, and I can take something to abort this migraine. Another reason I like it is because it comes in different formularies. You can take it as a pill. It also comes in a shot. Now, obviously, you can't buy that over the counter. But let's say I am having that yawning. I know it's coming. I know my migraine it's on its way. I've got a big presentation coming up. I wake up and sure enough, my head is hurting. I can get into my doctor's office and I can get a shot of an NSAID, and it works a lot faster than having to take some pills, every 6 or 8 hours. And so that's another reason I like the NSAIDs. They're non-habit forming. This is not an opioid. When we were looking at the medications that increase your risk of medication overuse, this was at the bottom, okay, the least risk and on that list. But all medications have side effects, which is why we talk about lifestyle changes so much. So the most common side effect of any of these NSAIDs is an upset stomach, okay? It can really irritate your stomach. That's why you always hear, you always take this with food. Or if you're someone who takes a acid reducer like omeprazole or famotidine, you want to take this with your famotidine or your omeprazole. There can be some indications where we say, I don't think NSAIDs is for you. If you have ever had a stomach bleed in the past, a GI bleed, then maybe we're not going to go with an NSAID. Or if you have ulcers, known ulcers in your stomach, again, this is going to worsen those conditions. So this probably won't be your first line. If your kidneys are failing and you don't have good renal function, your kidneys are responsible for getting this ibuprofen out of your system. And so if you put that extra work on them and they're already not functioning at the fullest, again, may not be the medication for you. And then in terms of what I mean by medication limit is the limit that I can take this the number of times per month. Again, it's my soapbox to prevent the medication overuse headache. It actually varies on which of those that you use because it is such a lower risk. You're able to tolerate these some of them more than 10 times a month and still not be at risk of the medication overuse. Next class of the rescue medications that you've probably heard of before if you have migraines are our triptans. So these are very effective. 75% of the patients who take this at the onset of their migraines, 75% of them within 2 hours, it's gone. And what did we say? Migraines typically last around 24. So if I'm vomiting, if I'm knocked down on the bed, 2 hours sounds a whole lot better than 24 hours. So these are wonderful medications. And then 50% of those people who take it and have relief, at the 24-hour mark, they're still going to be headache-free. And these are really good statistics when it comes to migraines. Again, there's many formularies with these. It comes in pills, it comes in nasal sprays, it comes in suppositories, because if I'm vomiting, it's going to be really hard to take a pill sometimes, depending on how bad this migraine is. These are prescription only, so you can't buy these over the counter. They have to be given to you by your doctor. You have good conversations about, there's a lot of different types. There's sumatriptan, rizatriptan, elatriptan, almotriptan, lots of triptans. That's why we just call them the triptans. Some of them work really quickly. So if you're someone who has migraines, who when that migraine hits, it hits quick. This is probably a good option for you. Some people, when their migraine begins, it's kind of a slow build. It's a slow build, and then it'll last a good 24 or 36 hours. So maybe you want robitriptan, which just doesn't, the onset isn't as fast, but it's really long acting. And so that might work better for your case. So these are things that you'll discuss with your doctor. The directions for them is the same across the board. Take one at the onset, and then you can take another one within 2 hours if that migraine is still there. The common side effects of triptans is some people will experience jaw tightness. Some people have an increase in their blood pressure, which leads us to a contraindication for this medication. If you have uncontrolled high blood pressure, you are constantly running 160, 170, I just can't get it down, these are not the medications for you. And this one, no more than 8 days or 10 tablets a month. Otherwise, you're really putting yourself at risk of a medication overuse headache. There are definite other classes of medications. The CGRP antagonists, ergots, ladmitan, these are all medicines that can be used, but I wanted to primarily focus on the NSAIDs and triptans since that's the most common, and that's what we're more used to taking. So now let's talk about prevention. Again, not just I have one right now, what can I do about it, but how can I try and prevent from developing these? Who qualifies for prevention medication? Because if you're thinking abortive, if I have 2 migraines a month, that's only 2 days a month that I'm having to take medication. Versus a prevention medicine, now it's every day of the month. I am taking this on a schedule, just like I take my blood pressure medication, because I'm trying to prevent myself from having a migraine. So the people who qualify for these are if you're having 6 headache days a month, or you're having 4 more headache days a month, but you've got some disability that's going with it, okay? Maybe you're having a pretty bad neurological symptom like, oh, I have that blindness in my eye, or I'm having the numbing and tingling, or my fatigue is just so severe, I don't even feel like I can go to work. Or if you're just having 3 or more severe headache days a month where I'm laying in bed vomiting all day, then hey, let's talk about prevention. These are decisions that you make as a joint with your doctor. It's ultimately up to you. Am I ready to take a medication every day to try and prevent this from happening? Or is it worth it to me to just combat my headaches, have 3 really bad days every month that put me in bed? It is individualized. You are the only one who can truly make that decision, but these options are available for you. But let's be realistic about our goals, okay? If we could put people on a pill and they wouldn't have any more migraines, then it wouldn't be the second cause of disability within the United States anymore. So we have to set our expectations up to be realistic. When you go on a prevention medication, realistically, you're just cutting the number of migraines in half. But I have patients that they're having 8 migraines a month. That's 2 a week. If you can go from 2 a week to 1 a week, they say, sign me up. If I can go from 1 a week to 1 every other week, give me that prescription. Because again, these are debilitating, they're severe. But sometimes I have patients that they go on it and they don't have any more. Like, they're the lucky ones, but that's the exception. That's not the rule. So either a reduction in the total number of migraine attacks, the reduction in the number of headache days. So this is something that you need to be aware of. It's a 2-month trial at the goal dose. So what happens is people take that medication every day for a couple of weeks, and they're still having migraines, and they say, this isn't working. I'm going to stop. What we have seen is that migraine medications, they kind of build up, and they finally get you to that goal. And you always need to give it at least a 2-month trial. If after 2 months, if I haven't seen any improvement, and again, it's no longer worth it to me to take this pill every day, well, you've given it the full trial period, but you always need to go at least 2 months. The next realistic goal is that maybe I'm not going to have a decrease in the number of total attacks, but maybe the severity of my symptoms will go down. Maybe instead of having so much nausea and vomiting that I'm not able to eat or drink anything and I'm getting dehydrated, maybe my nausea improves to the point where I can take something for nausea and it goes away, and I'm able to continue to eat and drink and function and take care of my kids. Headaches still might be there, but I still might be able to go to work, and I don't risk losing my job, and I don't risk losing my insurance. So these are goals when we're going on those prevention. And then again, reduction in the frequency of acute medication usage, because that's something we're worried about. I'm not going to stop talking about it. Instead of hitting almost that 10 days a month where I'm taking that medication, if I can drop it to 5, that's awesome. And then obviously we're trying to reduce the related disability associated with migraines. So the prevention medications, level A, level B, level C, these are getting into the weeds of which ones I want to use. Basically that same International Headache Society that I was talking about earlier, they have decided, hey, these up here, they're going to work. These should be offered. Topiramate, Depakote, metoprolol, propranolol, timolol, those are the level A, top of the top. This is what we're recommending. But unfortunately, everybody is different. Everyone responds differently. Sometimes we can start people on these medications in our level A, and they respond great. And then sometimes you put them on, and nothing happens. You wait the full 2 months, we're not seeing any kind of improvement. So then let's go to level B, because these are probably clinically effective, and sometimes people respond wonderfully to these. But according to the IHS, this is the level that we should be going in, and so this is what we do. Okay, so that's all I have in terms of migraines. Does anyone have any questions about anything that we talked about? Yeah.
So we were talking about preventative medications and going down from 8 a month to 4 a month. Have you seen people have success with the medication and then the medication stops working?
I have, yes. So that, again, it's so variable. No body is the same. We're so similar, but so different. I've had patients who have been on this medication and they said, oh, I've been on this one for 15 years. It works great. I don't ever want to come off of it. And then I have some patients who, it will work for a year and they're just really happy with the success that they're seeing. And then they slowly begin to come back and the frequency begins to come back up. And then whenever, again, it's all about co-joint decision making. Are we ready to try switching? Because anytime you switch, you could risk it getting worse. You could risk, I was originally at 8, then I went down to 4, and now I'm having 5 or 6. I could switch, and I could go back up to 8, or I could go back down to 4. So it's just a decision you have to make. that I have seen both. And again, I've seen some who they don't have any. So you just never know how you're going to respond, and it's all about, is this going to be worth it to me to take a medication every day, to maybe have some of the side effects with it, but is it worth it to try and have a better quality of life and not suffer from these migraines as often as I do? Any other question? Yes, ma'am.
I'm sorry, I missed the beginning, but when you're talking about ibuprofen
Mm-hmm.
for a regular headache,
So ibuprofen for a migraine works wonderfully. It is one of the first line medications. Any of those NSAIDs that I mentioned on this list right here is a first line medication for a migraine, not a tension headache, not a cluster headache, not, oh, that dog was barking all night, I didn't sleep good, now I have a headache. For a full-blown debilitating migraine, an ibuprofen. Now you want to make sure you get a good dose. We're talking 400, 600 milligrams, not just the one little tablet. You need a good 600 milligram dose. That's one of the first line medications to try and abort that migraine. And it's very, very successful. And that's why I love it so much, because it works great, it's cheap, you can buy it over the counter.
for regular, because if you said you can get those overuse medications, what about for, like, this is for my son, he gets tension headaches,
Okay.
I think, and then every once in a while he gets a migraine.
Okay. So for tension headaches, how often is he getting them a month?
Which,
Any type. How many days a month is he taking medications to abort a headache?
I'm not sure.
Okay.
He says,
So Tylenol works well for some people who have tension headaches. You know, that little dull headache that's annoying, it's there, it's not preventing you from doing your things. Tylenol works great for that. Ibuprofen can still work for that, but if you're having that many headaches a month, then you need to be seen by a doctor to make sure that you're not having migraines, to make sure that it's not maybe allergies, and if you will treat your allergies, then you don't have to start treating putting a Band-Aid on it and just trying to treat this headache that's really the result of your allergies. Or maybe it is because you're needing an eye doctor appointment. And if I will get glasses, then I can lay off of those headache medications because that's going to fix the root of the problem.
the stress, that's what I,
So stress, we did talk about, I'm not sure, I love behavioral therapy. And I gave a disclaimer because I know that when people come to me and they're talking about migraines and talking about headaches and I bring up behavioral therapy, they're like, what are you doing? Like, that's not why I'm here. I don't need someone to talk to. I need my headache taken care of. We know that, I have it right here, 80% of people who suffer from migraines, a trigger for those people is stress. And behavioral therapy is a wonderful tool. It is, this can keep you off of medications, is what it boils down to. If you can see a behavioral therapist and you can work with them and you can learn tools and coping mechanisms to deal with stress, then you can cut back on the number of headaches or the number of migraines that you have.
what type of behavioral therapy are you talking about?
Cognitive behavioral therapy is its own specialty within the community that you can be referred to. And these are people who have trained, they have studied, they have looked at the research. It's not just, oh, come talk to me about your problems and have that release. It is, when you feel this way, these are things we know you can do within yourself to help. It can be breathing exercise. It can be recognizing what your triggers are and knowing a healthy way to respond to cut back on the stress. It's a wonderful, wonderful resource for all of us.
You put exercise up there. I thought regular exercise is good.
It is, but there is a small group of people who regular exercise is good. A routine exercise is good. But there are some people who, they don't routinely exercise. And then they get out there and they go running one day, and now they have a migraine. Routine change is bad. We want routine. We want a routine exercise plan. But for those who don't, sometimes that will be the trigger.
Information about acupuncture and migraines?
I do not. I'm sorry. I did not look into that. I do know that the research is historically the research was mixed. Some research would come out and it would show that it's wonderful. Some would come out and it would show that it really didn't do anything. I do think that the scales are tipping and that they are beginning to shift to the side that acupuncture can really have a lot of benefits in regards to multiple things. But I haven't looked into it more in depth.
The first phase, because that's the part that kind of surprised me.
Absolutely. Let's go back to the 4 stages of the migraine, the prodrome, which happens usually 1 to 2 days before the onset of that migraine. This is the kind of like, remember when the tsunami happened and all the water flew out and it was like, it's coming. These are the signs that says it's coming. And it can vary for people. I have a friend, she yawns. She will yawn, just one right after another, and she knows, oh, I'm yawning, it's coming. Some people crave certain foods. Odd, they may be the type of person that's like, I hate olives. But they know when they start craving olives, guess what? I've got a migraine. It's here, it's coming, 1 to 2 days, and I'm going to be hurting. Some people have a specific type of irritability or a specific type of fatigue, something that is unique that they can recognize, and it's kind of just like that signal that a migraine is coming, and it's just what we see. It's pretty common. 3/4 of people who have migraines will have something like that. And it's not at the same time of pain. It is pre-pain.
Yeah, so I'm trying to figure out, that's the zone, I'm trying to figure out what would mine be.
And people,
Things I never
I probably blame something else there.
people who have them more regularly, and again, that's the benefit of keeping a headache diary. And I meant to put an example of a headache diary up there. You can Google image search, you can search headache diary, and you will see all different kinds. And it really helps you to kind of pick out those patterns. That way, like I said, you can't prevent it from coming, but if you know one's coming in the next 1 to 2 days, well, I'm not leaving my house without my medications in my bag, because as soon as that onset happens, I want to be able to take my NSAIDs or my triptans, and I can feel more confident. I don't want to have a medication overuse headache, but if I'm yawning a lot and now a headache's coming, I know that this is a migraine because that prodrome that I have every time has already signaled me.
And so sometimes, I think it's raining and that might trigger a migraine. Is that just coincidental?
It's not. Weather absolutely has been connected to precipitating factors for a migraine. Absolutely. It's more commonly heat, people who get really hot, and so it can pick up in the summer, but all types of weather. Remember, we're all similar, but we're also different. And so if you can pick out what your specific pattern is, it can be really helpful to your own health. Yes, sorry.
Oh, no, I was just, in case somebody else wanted to ask a question. 2 months, is that the usual prescribed duration of medication you give to people for any medication, or just these specifically, and why?
Just these specifically, because when we've done the research, that's what it has shown us, that it usually takes a full 2 months to reach that peak benefit of what we are going to receive from this medication.
Is there a resource I could see that research? Like, for instance, I want to understand, why did people see a benefit after 2 months? What was going on physiologically?
I would say one of the best places to find the most research, that's going to be the easiest to navigate, that you're not going to be going in 50 different sites. If you will go to the International Headache Society, They have a specific resource tab that it is geared specifically towards patients or providers, and they have wonderful, I mean like 30 one-page, quick, easy read handouts that will address so many different questions regarding migraines. So this would be the place that I would go to really try and educate yourself even better on migraines and what can trigger it and how can I treat it and which medication is the best for me. Wonderful resource. Any more questions?
Do you have a list of cognitive therapists?
Oh, there's a lot in the area. Your primary care provider could certainly give you the referral. Depending on your insurance, some places require a referral from your primary care, or some places you can just call. What is some ones in Fayetteville specifically? Because
LCSWs.
okay.
I'm trying to think of other ones. I know MANA does.
I know MANA, there's a Chenal that I've had a lot of patients. I don't want to like plug for one specific versus the other. Again, my clinic is in Springdale and I work more in that area. But if you will see your primary care provider, or you can just call, if you will look up LCSW, those are the social workers in the area, then you can get a list and you can call and say, do I need a referral from my provider or can I just schedule with you directly? I love that question. Any more questions? No? Well, I want to thank the library again for putting this on and allowing us to partner with y'all and try and give some good education to the community. We always really enjoy it, and so looking forward to the future sessions that we have. All right, thank y'all.
Thank you very much.
Mm-hmm.